Dementia adversely affects driving performance in even its mild stages. Studies have also shown that at the same time, some AD patients appear capable of driving safely for some time after disease onset. These studies are done in countries like Australia, America, where perhaps some of them are driving in very low areas of low traffic concentration. But suffice to say, they have quite a clean traffic record. Longitudinal data also shows that over time, the performance deteriorates with the severity of dementia. Again, not surprisingly. And in patients with mild to moderate dementia, a lot of time physicians find it difficult to identify which one should or should not drive. The fact that he has got a eyesight that is well corrected by his glasses, he can come to your clinic, talk to you, he can even try to convince you by juggling a ball in front of you. It's not enough for the doctor to identify whether this guy is able to, really drive safely on the road. So how can we assess them? Well, there are some studies. One study by Odenheimer in 1994 and another by Dobbs in 2002 showed that performance-based measures of driving skills such as on-road driving tests are pretty reliable, at least useful. But of course, you need some brave tester. For instance, in Tan Hock Seng, there is an occupational therapist who's quite brave, who would take patients on on-road driving tests and test them just like a driving test, probably with multiple airbags. There's a study also by Hunt that shows, and this is the Washington University driving test, that showed that traffic interactive performance-based road test examines cognitive behaviors, is accurate and reliable functional assessment. I think the long and short of it is that the best practice is that you've got to take the patient on on-road driving test. But what we do advocate is that preferably you have some pre-road screening, simulations. There are centers here that have simulations. It's like a car, and then there's a screen, and they have all sorts of scenarios, like somebody running out, and you've got the person tested got to jam the brakes and so forth. So that at least, you've got to pass the simulations before they go onto the road. I mean, otherwise, God bless the testers. Now, what can we infer? I think that, a diagnosis of dementia does not automatically mean that this person is incapable of driving. The decision should be based on dementia severity or demonstration of impaired driving competence. And of course, it depends also on the society's, how much risk the society is willing to stomach. If you want an absolute risk-free sort of road, then certainly we have to draw a very high threshold for people to prove before once they have dementia, before they're allowed to drive. But if we are to take a more balanced approach, then I think we got to then look at some form of testing and assessment. Also remember the disease will progress. So repeat road testing at regular intervals, usually 6 to 12 months or earlier, is suggested. I know that recently, the testing for elderly is now 3 years and all that. There's been a lot of struggle, and we are talking about normal elderly. I think as clinicians, all we can say is that if you have a reason to suspect that there's some problems, even before the 3 years, you should retest the patient and perhaps send the patient for a driving test in one of the centers that provide that service. If a patient is assessed to be unsafe, insists on driving, what do we do? This is a very common scenario. Well, first of all, I guess the first step is to enlist the help of family members to persuade them to stop driving. Always try the gentler approach, the more respectful approach, assuming that the person would be, sensible. But again, you say these patients have dementia. Can they ever be persuaded? Are they logical in their thinking? Then you got to also, a lot of times, explore and arrange alternative forms of transport. He may want to drive because that's how he's going to meet his kaki. That's how he's going to drive to botanical gardens. You got to find a solution so that he can still meet his needs. In the literature, it says that if they really do not want to stop driving, you got to then prevent access to car or car keys, hiding the car keys, or immobilizing the car if necessary. In fact, the literature that I found said doing all these things is ethical, as that's what the author says. The patient is absolutely inflexible and insists on driving, and really, you're at the end of the road, you really don't know what else to do. Then I think, and you feel that this person there's a reasonable risk because he lives in a very densely populated area. There are children, schools around, bus stops are always full of people. Then it's ethically and professionally permissible. Now, this is just a guideline. I mean, nothing in the law that says whether it's ethically, but you're probably unlikely to be sued, less likely to be sued for breaching confidentiality than to be held accountable when this guy jams into a school full of children. To breach the confidentiality and file a report to the relevant licensing authorities. I think that you have to do when you really have no choice. Living alone is another problem because we do get referrals at the hospital from either social workers about patients who live alone. There are also people with family but absolutely refuse to live with their family, and they're living alone and they're deteriorating. Family goes and visit them and find the whole house in a mess. First they think that somebody robbed the house, but actually it isn't. It's just the patient's decline. What are the potential hazards? I think we've got to think holistically for this patient. First of all, there's poor compliance with medical treatment. They stop taking their medications, and including dietary instructions. One of the most challenging group of patients to manage are demented patients with diabetes. They start eating and all that, and it becomes very difficult, and they have binges. Malnutrition is a problem. They don't eat right. They don't forget to drink. They become dehydrated. Poor hygiene. They don't bathe. And they start to rummage dustbin and so forth. Then there's a lack of safety awareness. Falls occurs at home, burns, scalding injuries, accidents when they cross the road, behavioral problems and psychiatric symptoms. Now all these create safety issues. They may have hallucinations of ants, and they start boiling water and pouring it into their own house. I had a patient who started pouring in the neighbor's house because they saw ants in the neighbor's house. So the safety issues can extend to neighbors as well. And if they leave their cattle unattended to, it's a potential fire hazard. Then there's poor judgment, and it exposes them to mistreatment, fraud, exploitation. They may fall into one of these Nigerian scam, whatever. Overall, there's increased risk to safety and well-being of patients as well as for the immediate neighbors. But again, like all things in dementia, it does not automatically again mean they cannot live alone. Judgment should be based on an assessment of their decision-making capacity, again with respect to their own placement, and then the ability to continue living alone in the community without posing too much risk to self and to neighbors. Sometimes, the risk is not to self, but and the patient said, I'm willing to accept that, and the family said, we're willing to accept that. But I think risk to neighbor is also relevant because most of them live in HDB flats, and I think public safety in what I still think is a communitarian-based society, it's important, I think. And I'm sure you don't want to be living next to a person who is what we call living dangerously. So there's a need to consider potential negative social and physical impact also of moving from familiar environment to institutional care. This is looking at the flip side of the coin of too easily moving them. Now, if a patient with dementia has adequate decision-making capacity and you assess them and you think they're quite all right, at least for the moment, then we have to support the decision by trying to simplify their task at home. Not easy because they're so used to a certain routine. And then using available community resources to try to support them, Meals on Wheels, befrienders, and so forth. Regular assessment, again, because they are declining. Now, simplifying the daily tasks refers also to the physical environment, making it simple. But let me tell you, it's very difficult. I used to be a volunteer. You try throwing away one piece of object from the house, you get thrown away before that. Yeah, so there is a lot of resistance, even in elderly. I think in demented elderly is going to be even more difficult. But the good thing is that hopefully they will forget that you have taken that out of the house. Then, for patients with doubtful decision capacity or possible safety issues, what we should do is actually have a formal evaluation, an assessment, preferably with the occupational therapist, and sometimes we even call in the physical therapist and the speech therapist. We want to look at safety with respect to self and to neighbors when carrying out activities of daily living and tasks such as food preparation. Sometimes it will include things like, there's some patients who are living alone who are still going across the road to buy food and so forth. Sometimes I tell the family to play detective. Every now and then, just trail him, and see how safe it is. If he's looking left and right before crossing, it's fairly safe. But if you see him just dashing, walking across, and there are a lot of cars with the jam that brakes and all that, then I think you've got to decide between giving him his happiness of living alone and his safety. And a lot of times I tell the family, it is a choice between letting him have what he wants and putting him in a safe environment. How he handles money. Does he wait for his change, If he doesn't wait for his change, and he continues to live alone, you may want to give him small denomination. How does he handle his basic hygiene, like bathing and laundry? Does he comply with his medication? Basic security. Does he lock his door? OT will usually go there and ask them, make me a cup of tea, you cook or cook me a bowl of Maggi mee or something like that. And they assess the safety of these patients. And then they come up with a report. And we have to make a sort of collective decision. Yeah. And we also we talked to some of the patients. Some of the patients have this phobic response towards institutional care. That's because in their long-term memory, the nursing home used to be a terrible place. So what we do sometimes actually bring them for a visit and they say, hey, this is a nice place. And they settle down pretty well in the new environment. I think the goals of care when dealing with these patients is optimize residual cognitive and functional abilities in a safe, familiar, and comfortable environment. Protect them from abuse and exploitation optimize the quality of life, and as far as possible, we still want to provide premature institutionalization. So, I mean, these are goals of care. It requires a lot of community resources, a lot of doctors' time, and sometimes also family. And do not make it a sort of a spinal response that every time you have an elderly living alone at home and have children, you start scolding the children. A lot of times it is a choice of the elderly who wants to stay alone. And I've learned from my patients that is the case, in fact, in quite a majority of the cases. I'll just do a recap, last few slides now. The general ethical imperatives. I think this is on the basis, again, like I said again, we do want to respect some of the ethical and professional principles in our care. First of all, the dignity of the patient should be respected at all stages, irrespective of their cognitive and functional status. When they're in early stage, respect them as an early dementia. When they're in advanced stages, respect them and see what we can do for them in terms of dignity and care as an advanced dementia. And at different stages, there are different needs. Therapeutic goals should therefore be directed at how life is experienced by the patient under the contextual circumstances specific to that stage of disease. Some people feel that we shouldn't make this judgment on quality of life. I am from the school that think that we should try and make a judgment and discuss, better than not make that discussion and then, make certain decisions under the guise of, quantity of chances of success of treatment or worth to society and so forth. I think the more open we are with this discussion, the better the decision will be for the patient. And it should be coherent and appropriate to the functional status, individually tailored, adjusted at different stages, and an emphasis on quality of life. I think overall we would do, as a profession, we strive to delay, prevent, stabilize, or cure dementia. But I think where there are limitations, we have to acknowledge, and we should avoid protracting life and morbidity artificially in the severe stages of the disease at the expense of comfort and quality of life. I think too often we've seen very advanced demented patients with their basic things such as pain and itch neglected, and yet, aggressive intervention just to find out where is the primary of the tumor, of this stage 4 tumor. I think we've got to move away from that sort of practice. Yeah, with that I thank you.